Assalamualaikum and very good day to everyone. We are from Group AA. Today we would like to present a case on Paediatric. So these are our patient data. Our patient is Malay male, 7 months old with actual body weight 5.2 kg and height 65 cm. Both weight and height is not in estimated range according to PITS protocol, where the body weight should be 7.5 kg and height should be 68 cm. His BMI is 12.5 kg per meter square and BSA is 0.31 meter square. For the chief complaint, he has chest cough for 4 days and fever for 1 day. The last documented temperature was 38.5 degrees Celsius and the last paracetamol was given at 7 p.m. He went to seek GP consultation and was informed that the lung was clear and only received paracetamol. On April 2019, he has been diagnosed with epilepsy and was given Epilim 22 mg BD syrup. And on July 2019, he has been given prophylaxis of urinary tract infection with 3-metropin 9 mg OD syrup. Both mother and father are 27 years old and he is the only child. His parents denied any smoking or alcoholic drinking, and his mother is housewife and father is working as a salesperson. He has been diagnosed with dengue Walker malformation on week 7 and major structural abnormalities on week 23. He was born via emergency lower segment cesarean section on week 26 and born premature with 2.1 kg birth weight. For immunization history, patient is 7 months old and is vaccinated up to 6 months with additional protection with 3 doses of pneumococcal vaccine and 1 dose of rotavirus vaccine. For developmental history, he has speech vocalizing and social not focusing with GM headlight and able to roll over. Patient was born premature and got second hospitalization due to presumed meningitis and epilepsy, third and fourth hospitalization due to cystoperitoneal shunt and bronchopneumonia, and more hospitalization for revision of shunts and urinary tract infection.
Okay. For his progress note, on the 3rd of October, the patient was admitted to the hospital with respiratory rate of 55 breaths per minute, which is tachypnea, with rapid breathing. He also had a fever and chesty cough. Lung examination also showed that he has mild crepitation on his left lung. He was on the impression of bronchopneumonia, thus he was started with IVC penicillin 50,000 unit per kg, QID and syrup PCM 50 mg per kg. His all meds was continued and CNS test was instructed for the patient. However, after 1 hour, IVC penicillin 260,000 QID was then stopped and IV cefuroxime 25 mg per kg was initiated and syrup Bactrim was withheld. Few hours later, his lungs were clear and his temperature was starting to get lower. He was on the UFEME result was out and he has a positive result of bacterial growth in his urine. He was on the impression of presumed UTI. Thus, the IV cefuroxime and PCM is continued for the patient. By 1500, patient's pulse volume started to reduce and patient was becoming more tachycardic. He was an impression of presumed urosepsis. Thus, he was initiated with IV NS bolus 50 ml per hour and his IV cefuroxime dose was increased from 130 mg to 260 mg. The next morning, his lungs were clear and he has a good pulse volume. He was still on the impression of urosepsis with impending shock, and the patient was prescribed for cefuroxime for 5 more days. His case was to be discussed with the nephrologist on changing his prophylaxis antibiotic and for further plan. At 2:15 p.m., the patient was febrile with temperature of 37, and the patient's condition seemed to improve. However, the mother noted a smelly urine, which indicates that there is still an infection in his urinary tract. The patient was still in impression of urosepsis with impending shock. Patient's blood CNS was to be traced, and based on the nephrologist review, the first breakthrough of UTI happened 3 months after trimethoprim prophylaxis. They suspected neurogenic bladder was causing poor urinary stream, and which leads to the patient's UTI. KUB ultrasound is to be repeated in this patient to assess his renal function. Okay. On the 7th of October, the patient condition is febrile with temperature of 37, and his impression was he has resolved urosepsis with underlying UTI secondary to underlying possible neurogenic bladder. His IV cefuroxime is still continued for 10 days, and after discussion with nephrologist, IV cefuroxime is continued and dose is confirmed with nephrologist is at 15 mg per kg OD. On the last day, the patient condition is improving. He is febrile with temperature 37 degrees Celsius. His diagnosis was resolved urosepsis due to breakthrough UTI and secondary to neurogenic bladder and post-stream. IV cefuroxime is continued, and if the patient is discharged, is IV cefuroxime is changed to oral cefuroxime 75 mg DD for first day, and then changed to 75 mg OD for the next 6 months.
So the first diagnosis is bronchopneumonia, where patient is present to the hospital tachypnea with an RR of more than 50. So patient also present with fever and also chesty cough. Besides, patient possesses risk factor like comorbid conditions, which include premature birth and low birth weight. Besides, patient is also younger than 2 years old and is hypoxia, which he needs face mask to maintain SpO2 level. So the recommended treatment as suggested by Paediatric protocol, CPG guideline, and National Antibiotic Guideline is stated that the first line would be beta-lactam, which is the penicillin group. So patient was initially started with IV penicillin 50,000 U per kg, QID, which means 4 times a day, for the diagnosis of bronchopneumonia. So according to the recommendation, the dosage was within the range and suggesting that this management is appropriate. So second line antibiotics should be initiated only when there is no sign of recovery or patient remain toxic and ill with spiking temperature for the next 48 and 72 hours. However, patient does not show any of these symptoms, but IV penicillin was changed to IV cefuroxime within 1 hour of initiation. Next, the diagnosis of UTI after the confirmation from the urine full examination result where the bacteria is seen in the urine. So besides the patient having the signs and symptoms of unexplained fever and also failure to thrive is also the list of evidences to support UTI. So the recommended treatment as suggested in Paediatric protocol and National Antibiotic Guideline. So patient was initially on prophylactic medication, which is trimethoprim 9 mg OD syrup. However, there is a breakthrough infection of UTI throughout the period, and hence, as suggested, a child that develops an infection while on prophylactic medication should be on a different antibiotic and not on a higher dose or the same prophylactic antibiotic. So with that being said, cephalexin or cefuroxime can be used in patients with prior antibiotic. So hence, the preferred and alternative treatment is not suggested, suggesting that the management of IV cefuroxime of 130 mg TDS is appropriate. Okay, next is the diagnosis of urosepsis, where the current diagnosis of neurogenic bladder with patient of neurogenic with right hydronephrosis suggests that the urine retention in the bladder itself has led to swollen kidneys and hence infected the upper urinary tract. So the treatment would be antibiotic, which the patient is already on, or surgery to repair the urinary tract blockade. So with that, early management with clean intermittent catheterization, which is CIC, should be given to ensure a complete and safe bladder emptying with the improvement of the incontinence.
So for the possible dilated problem in this patient, there might be ineffective prophylactic management for the UTI. This patient has been given syrup trimethoprim 9 mg OD since July 2019 for 3 months. The urine full examination result on the 3rd of October and patient symptoms showed that the patient developed UTI. Thus, resistant to the antibiotic causing the recurrent urinary tract infection despite the use of the prophylactic antibiotic. So for the management, the alternative antibiotic should have been used for the management of UTI and not the high doses of the previously used antibiotic, which is trimethoprim. The alternative antibiotic includes cefuroxime and cephalexin.
Moving on to the pharmaceutical care issues. Firstly, the inappropriate management of bronchopneumonia. On the first day of admission, the first line of IV C-penicillin was changed to the second line IV cefuroxime after 1 hour of initiation without proper justification. Although can consider about the reason, doctor want to minimize the use of antibiotic as cefuroxime could treat both bronchopneumonia and UTI. But as a pharmacist, we need to discuss with doctor whether the use of the same antibiotic for 2 indications is outweigh the use of first-line treatment for bronchopneumonia. We need to see which one is more effective and safe. And then pharmacists should also involve in every antibiotic decision-making to guide on the appropriate antibiotic treatment. Next is the anemia problem. On the first day of admission, patient has low level of hemoglobin and also MCV, which indicates iron deficiency anemia. But then he was not initiated with proper management of anemia. And then the syrup ferric ammonium citrate and folic acid was initiated on 6th of October, which is late initiation. So for the management, the FAC and FA should be earlier, which is on the 3rd of October. And then for the prophylaxis, daily oral iron supplement like ferrous sulfate drops and infant vitamin drops with iron could be given. Thirdly, the unnecessary use of the paracetamol. So the paracetamol is given from 3rd of October until 8th of October to resolve the fever. However, patient's temperature has returned to normal temperature on the 4th of October. So patient is febrile on the continuous day. So for the management, the paracetamol should have been discontinued once the patient's fever has resolved, which is on the 4th of October, to reduce the drug burden on the patient. Fourthly, the lack of actions for management of the neurogenic bladder. So UTI is possibly due to the neurogenic bladder, so the appropriate management of urogenic bladder should be prescribed to the patient. So the proper investigation should be done to confirm the diagnosis of the neurogenic bladder in the patients, like physical examination, imaging test, and urodynamic test. So the appropriate management like catheter insertions or surgery should be taken to prevent the further complication. Fifthly, the inappropriate dose of epilim. So according to BNF, the initial dose of epilim should be 10 to 15 mg per kg, and then the maintenance dose is 20 to 30 mg per kg per day. However, the dose given in ward is 22 mg BD, which is too low for the patient and may be suboptimal. So for the management, the dose of epilim should be adjusted according to the patient's current body weight. So the initial dose should be between 52 to 28 mg per day, and the maintenance dose should be between 104 to 156 mg per day. Besides, also need to monitor the frequency of seizure attacks and also monitor the drug concentration to avoid adverse effects.
Okay, to ensure the effectiveness and the safety of the treatment to this patient, some monitoring plan will be implemented. First, monitor the vital signs such as temperature, heart rate, respiratory rate. It is to ensure the efficacy of antibiotic and TCM in elevation of the bronchopneumonia. Secondly, monitor WBC and CRP level to check on effectiveness in eradication the infection. Thirdly, examine patient general status, such as appetite and comfortable status. This for monitor overall patient condition and to see patient improvement after initiating the therapy. Monitor food blood count as to ensure the effectiveness of oral FAC and folic acid in treatment of the anemia. Then conduct the culture and sensitivity test to identify the causative microorganism as to narrow down the spectrum of antibiotic. Apart from that, monitor the renal profile, for example, creatinine clearance, serum creatinine, as certain drug is excreted through kidney. Besides, since patient has high risk of proceeding to septic shock due to urosepsis, it is crucial to monitor the level of WBC count. Next, monitor the liver profile, as serum epilim has high risk of causing fatal hepatotoxicity. Next, check on sign of hypersensitivity reaction in order to monitor the allergy symptom after administration of antibiotic or any medication. Next, monitor the side effect of medication such as cefuroxime and epilim. Finally, monitor urine input and output as to monitor kidney function and status of the urine retention of patient due to hydronephrosis and also neurogenic bladder. So here are references. That's all from us.
Thank you.